This conference will now be recorded.
Great. All right. Well, hello everyone. Welcome to tonight's lecture question and answer session with Dr. Ulrich Batzdorf. I'm going to quickly introduce him and then I'll probably just have you introduce yourself, Rick. But Dr. Batzdorf has been the chair of our C board. He is an adult neurosurgeon out at UCLA. He's really been a pioneer in the field of syringomyelia, so I think I've seen a couple of people send in some questions specific to that and things of that nature, and spine. So that's going to be really important for us to go over. And I know, just to give everybody a little bit of housekeeping, what we're going to want to do is, if you can, please make sure you're muted and turn your camera off unless you want to be on camera on the video recording. We're going to have Dr. Batzdorf also kind of take us through a sort of introduction based on the questions that you had all sent in. He's going to kind of introduce a couple of different topics, and then as questions kind of come in, we'll answer them as we go. So I think with that, I'm just going to pass it back over to you, Dr. Batzdorf, and see if there's anything specific you want to introduce yourself or say before we kind of get started.
Well, thank you very much, Caitlin. I do want to say a few things in a general way. First of all, these are extraordinary times, and so we have extraordinary solutions to the problem, some of which are really magnificent, and I cannot think back of a previous time when we had this kind of interaction, which is fantastic. I want to thank Bobby Jones, CSF, for doing an incredible job in making this possible, led by Dorothy Poppy and with Caitlin spearheading this event and being of immense technical assistance together with Mary Poppy. And I really can't say enough about the dedication of these folks to the challenges that syringomyelia and Chiari malformation continue to pose, not only for patients, but also for the scientific establishment, because there are many, many aspects of these disorders that we have yet to understand completely. And obviously, understanding them is essential to being able to treat them effectively. I think the Bobby Jones and Chiari Syringomyelia Foundation is really spearheading some of these ventures. I'll refer to them later on in our discussion again, and have been tremendous help in not only educating patients, but educating physicians, including myself, other medical caretakers. I've learned a great deal in very practical terms from my association with this group, and we have a long way to go. As you know, there are many comorbidities that are associated with Chiari malformation, with syringomyelia and related disorders, including tethered cord, which we're looking at the moment. And we don't understand the exact relationships, never mind how to treat some of the connective tissue disorders effectively. So we have our work cut out for a long time to come. I want to say something on a personal note. Caitlin mentioned that I'm an adult neurosurgeon. That is to say, I am not a pediatric neurosurgeon, and I treat adults. And our focus today is going to be on syringomyelia, so it's not inappropriate for me to tell you that my interest in syringomyelia dates back almost, well, certainly 4 decades and more, when I first saw a patient here in Los Angeles who had sustained a severe diving injury in a shallow stream and had a complete spinal cord transection as a result. And this person was in high school at the time his accident occurred. He went on to complete high school, college, law school, and went on to practice law, and was an inspiring person. He came to me after all this with a problem of syringomyelia, and I vaguely knew what this was, but the diagnosis at that time, there was no MR scanning available, was made by contrast injection into the spine. And once I had a diagnosis, there was practically nothing written about it. One book, sparse information, and I remember getting on the phone and calling people in England and in Australia to get help with this. And it was this that started me on the road to look into syringomyelia, and then by relation to Chiari malformation, because many patients with syringomyelia do have a Chiari malformation. So that's just by way of introduction. And I want to make a few general comments at the risk of insulting some of you who know a lot about this and perhaps even know more than I do, but I want to make some general statements so we all have some basic concepts. But the brain and the spinal cord are, of course, covered by bone, the skull and the spine, but inside they're covered by three layers of tissue, which collectively are called the meninges. And as you know, when these become infected or inflamed, we are all familiar with the term meningitis. And these membranes play a very important role. There are three of them, and I'm just going to reach over here because normally I would be sitting with my coat on, and there's a reason I want to show you this. If you think of these as three layers, there's the outer one, the dura, the hardest one. There's an inner one that's sort of thin, that's my shirt. And then there's one that's closely applied to the skin. It doesn't really separate from the skin. This is the dura. The thin one, my shirt, is the arachnoid. And any of you who know Spanish know that arachnoid is a Spanish word for spider webs. And our forefathers, when they studied anatomy, looked at this and said, you know, this looks like a spider web, you know, like, yeah, let's call it arachnoid. And then the pia is the one that's attached to the spinal cord and brain. It is really not separable from it. And we all have a watery fluid that is produced 24 hours a day, nonstop, from blood, filtered from blood, and taken back into the bloodstream at the same rate at which it's produced. And this fluid is beneath the arachnoid, beneath this thin membrane. And so you can envision the brain and the spinal cord as being encased in this watery fluid. And there are many functions this fluid performs in health. If you want to think of it, you can say that when you bump your head getting out of the car, that energy of the bump to the head is absorbed by the fluid rather than being transmitted directly to the brain. And if you bump your back, the same thing, that energy is absorbed in part by the fluid cushion around the spinal cord and not transmitted directly to the spinal cord. And so this cerebrospinal fluid, or CSF as it's abbreviated, is immensely important in our understanding of the conditions that we're going to discuss today. Primarily, the focus today is going to be on syringomyelia. I'm going to start out by making a few general comments, introductory comments. Syringomyelia is encountered in two general categories. The first is Chiari-related syringomyelia, and if I could show those.
Pulling them up. I want to get to the correct slide. Here we go.
Yeah.
Sure.
Do I see them?
Yes.
Yes. No, that's not the correct slide.
Oh.
I want 9, 10, and 11.
These aren't.
9, 10, and 11.
Oh, I see why. Is it not this one? Let me just pull it up this way, I guess. It should have been, so the one that was numbered 9 was this one.
And that you showed me was pink.
Oh, sorry. Is it not this one?
Yes.
Okay, good.
So it's a little bit hard to see from the way these are reproduced, but what you can see, can I point to this? No, I guess I can't.
I can give you the ability to, hold on one second.
Yeah, I got it. Okay. So here is the base of the skull. Can you see that? And you can see.
Here, try now.
Disappeared.
Oh, it went away? Oh, 1 second. You should still be able to, now you're sharing your screen.
Yeah, but I'm not seeing the pictures.
No, they went away. Okay.
They were better before. Well, I should put those back up, and I will point out what I need to point out. So the basic problem with a Chiari malformation, and this is a very simplified form of approaching the problem, is that the space for the cerebellum, which is this part of the brain, is too small. So it is pushed out of the skull into this area here. And this can happen with different types of abnormalities. Here is one called basilar invagination, where this bone rides high and makes this space too small. Here, this membrane is much lower in position than it is here, making this space too small. And if I could have number 10 and 11. Here's another one where you can see that bone is tipped up as it is here, and the cerebellar tonsil, you can see, projects down. It's being pushed out because the space is too small, and there should be one more. Yeah, here is somebody who has a large arachnoid cyst, which is in fact a benign thing, but because it takes up room, it pushes the cerebellum out of the skull into this space right here. And so we have, in a very general way, we have a situation where the space for the cerebellum is too small, and it pushes the cerebellar tonsil, which you see right here, out of the skull to a varying degree over time. And in this particular patient, you also see the development of a cavity within the spinal cord, a syrinx cavity associated with this downward displacement of the cerebellar tonsils. I want to go back and make some general comments about syringomyelia as well. So if I could have slide number 4. We talk about syringomyelia as primary spinal syringomyelia as differentiated from syringomyelia, which is seen as we have just illustrated in patients with a Chiari malformation. Primary spinal syringomyelia exists in situations where tonsillar descent is not the problem, but the problem originates in the spine itself. And the most common form of primary spinal syringomyelia is related to spinal injuries, just as it was in the patient I mentioned to you who's got me started on this. And if I could have number 4 and number 5.
Is this not number 4?
I don't see it.
Is it not sharing? Oh, sorry, everyone. This one?
Yeah. Okay. This is an artist illustration and shows a fracture of the cervical spine right here, and impinging and crushing the spinal cord. And when that is corrected, the spinal cord is restored to some degree. Whether the function is restored is always another question. But this is the most common type of primary spinal syringomyelia. We also see primary spinal syringomyelia in patients who've had meningitis, in which case there is scarring in the space that I talked about before, the subarachnoid space, so this thin membrane, the arachnoid, becomes adherent to the spinal cord itself and may form pockets. We see it in other forms of inflammation, people who've had a hemorrhage into the spinal fluid, and we all, excuse me just a second. We all handle blood in the spinal fluid differently. Some people develop a profound reaction leading to scarring. Other people absorb the blood and never know the difference. And then there are obstructions of the subarachnoid space. Yes, this is an actual case from which the artist actually made the drawing. And you can see how the syrinx cavity developed as a result of this narrowing of the subarachnoid space here. Notice, by the way, that the spinal cord and the relationship to the fluid compartment outside it is perfectly normal below the injury. It's here where the space, the fluid space, the arachnoid space is compressed. And there's some improvement here after surgery. It doesn't look completely normal, nor was this patient completely normal. And the syrinx cavity has partly collapsed, not completely collapsed, but partly collapsed. And any kind of process that can produce scarring of the arachnoid or narrowing of this subarachnoid space can potentially result in syrinx development. Another situation, and you may show slide number 6 now, in which this is apparent, is an arachnoid cyst. And here you see a patient who has, probably from birth, a web that narrows the canal right here. And in the operating room, you can actually see this same area under ultrasound imaging. And the effect of this is exactly the same, that the arachnoid cyst can produce blockage of the CSF and result in a syrinx. And we'll talk about that shortly. The other situation that may occur, and it is confusing to patients sometimes, if a tumor obstructs the subarachnoid space, a spinal cord tumor, then it may result in syringomyelia developing. Tumors, particularly certain types of tumors, also have the ability to secrete fluid within the tumor, and that is a tumor cyst, which, in my view, is a distinctly different situation from the syringomyelia. Now, I want to show and make one other general comment. Could I have slide number 12? This is what you're looking at here is a typical syrinx. And actually, this happens to be a patient who has a Chiari malformation, but you can see this is a somewhat irregular, blunt-tipped thing. The cord, the spinal cord, is widened by it, and this patient undoubtedly will have symptoms from it. So it is distended. It's often rounded at one or both ends. It's, if you looked at it in cross-section, it may be more on one side or more on the other. And it may have segments like this one. You can see it's got a little separate, almost separate pocket. And sometimes you see an area in the cervical region separated from another region in the thoracic region. Now, if I could have slide number 3. This condition, syringomyelia, is distinct and very different from a residual central canal. No, that's not it. Yeah, will that enlarge any?
I
Yeah,
don't know why it's, oh, is that better? It doesn't get too clear.
yeah, that's number 3. And you can see here a thin line. The spinal cord is not expanded by it. Unfortunately, this is not quite large enough to see that it tapers into a almost invisible line, both above and below. And I think if you have number 7. No, no. Okay, we'll leave that as one missing, but we'll leave that. But the point is that these cavities are completely round. They're in the center of the spinal cord. They don't expand the spinal cord, and they are part of normal development. This slide is taken from a paper by Japanese colleagues, and it shows the outline in the spinal cord of this rounded cavity lined by normal cells. And I don't know whether you're able to see the lower part of it, but it shows that this cavity disappears. It is present in all of us at birth, and it disappears most rapidly in the first 10 years of life. But that said, it may be present in some individuals. In this Japanese study that I always cite, there were people in their 90s who still had a small focus of residual central canal. So it usually disappears by age 10. It's a thin line. It's central. It may be segmented. There may be portions of it in the neck. There may be portions of it in the thoracic region, disconnected, but they have no clinical significance. And when I see patients, and I see many of them who come with a diagnosis of, quote, syringomyelia, and I'll get back to that, unquote, because the radiologist reads it as such rather than residual central canal, or as one of you who sent a question already mentioned, hydromyelia. When somebody presents with that and has symptoms, my challenge as a clinician is to find out what their symptoms are really due to, because they're not due to this. And I've followed patients for many years and have seen no change in that. Theoretically, judging from the Japanese figures, one would have to assume that the central canal may disappear even as we are adults, but we don't at this time have any knowledge of what the processes are that result in disappearance, or as it's called technically, involution of the central canal. Now, the central canal has one other important and relevant consideration, which I think we need to talk about. Quite a number of years ago, a man who was very well known and respected in the field, Dr. Tom Milrat, made the suggestion that the presence of the central canal may explain why only some people with a Chiari malformation and only some people who had a spinal cord injury develop syringomyelia. That is to say, the presence of the central canal in somebody who has descent of the cerebellar tonsils, or the presence of a residual central canal in somebody who sustains a spinal cord injury, makes them more likely to develop syringomyelia on top of it. That was his suggestion. And there is some appeal to that consideration. Our present understanding of syringomyelia, and here I would like you to show slide number 8, if you would. Yeah, you had it. You had it. No, disappeared. You had it. First thing that you showed. Before that. 8. Yeah, that was it. Yeah. Thank you. Thank you.
Okay.
So this is a slide from a paper by Dr. Edward Oldfield, who unfortunately died a few years ago, who was a pioneer in the field of understanding the pathophysiology of Chiari malformation and by inference syringomyelia. But his theory was that the cerebellar tonsils, which I'm pointing to here, pound on the spinal fluid jacket around the spinal cord and then drive fluid into the spinal cord to form a cyst. And one of our colleagues in Australia, Dr. Marcus Studley, actually demonstrated that this fluid can migrate in the space surrounding blood vessels that nourish the spinal cord. And this, for the our present understanding for the formation of syringomyelia in association with Chiari malformation. And as is shown here at the bottom of the picture, if surgery is done to increase the space and diminish the size of the tonsils, then the syrinx will disappear. I think you can probably see that down here. And his colleague, Dr. John Heiss, who is very active in the Bobby Jones Chiari Syringomyelia Foundation, also contributed significantly to our understanding of syringomyelia, because by a very similar mechanism to that which Dr. Oldfield described, if you can just sort of picture the obstruction not at the foramen magnum, but can picture the obstruction further down in the spine, whether it be due to an arachnoid membrane or a scar from an injury or a tumor, can result in the same pounding action of the tonsils or pounding action of the fluid to drive fluid which cannot go past this obstruction into the spinal cord and thereby form a fluid cavity in the spinal cord, which is called syringomyelia. And obviously, if there's been an injury to the spinal cord, as again, Dr. Millerant demonstrated beautifully with some illustrations of anatomy specimens, that fluid can actually enter into an area of injury. So that's basically our understanding. And having said that, I want to take a moment to say that, and our focus today is on spinal syringomyelia. The focus is as follows. We have come away with the idea that just as in patients who develop syringomyelia in conjunction with the Chiari malformation, there is an obstruction to the circulation of spinal fluid in the spine itself. Our focus in treatment is, if at all possible, remove this obstruction rather than simply divert fluid out of the cystic cavity. That said, let me say historically, the only thing we had available 30 or 40 years ago to treat syringomyelia was to put a tube into the cavity, a small plastic tube into the cavity, and drain the fluid out of that cavity into the tummy or into the chest or someplace else where it would be absorbed back into the body. But these tubes, by their very nature, and I can go into it if we have time today, have a very high failure rate. We studied it one time and found that 50% of them fail within the first 5 years of placement. And the idea of trying to find the focal scar and remove that rather than putting in a piece of tubing, so that we're really dealing with the abnormality that is the cause of the problem, is, as I'm sure you would all agree, much more appealing and has much, much better long-term effects. There are none of us are immune from developing scar tissue, and the propensity to develop scar tissue in any situation, whether that be from an appendectomy or from spinal cord injury, is probably in part genetically controlled. But removing the cause of the obstruction is much more satisfactory. Unfortunately, patients who develop syringomyelia following meningitis, and here infection with tuberculosis, tuberculous meningitis is one of the terrible offenders, at least in past history, have so many areas of scar formation and adhesion that it is not really technically possible to remove all these adhesions, let alone that they would probably reform and reform more vigorously after they've been removed. So that isn't a good solution. And for people like that, and with similar conditions, we still have to resort to placing a shunt into the cavity, recognizing that it may need to be revised during a patient's lifetime. So that's sort of a summary of where we stand. I would like to open the floor to questions, and perhaps I've addressed some, but I'm happy to try to answer questions if I can.
Sure. Well, that was an outstanding overview. Absolutely. We've had a lot of really good questions come into the chat. They're really thoughtful, but I'm going to get to a couple that came in ahead of time, just in the idea of fairness. So one of the questions was, can Chiari symptoms worsen after a trauma, so a car accident, something like that?
I would like to address that point, citing a study that, again, was published by Dr. Millerant 25 years ago or so. He looked at this question, not specifically car accidents, but trauma. And my recollection is that in the study that he published, 24% of patients who presented clinically had a history of some kind of head trauma. It doesn't have to be severe. Now, look at this question slightly differently. The assumption is that the arrangement of bone and cerebellum is what we're born with. And as you may know, many patients with Chiari malformation and syringomyelia may develop symptoms leading to surgery in childhood. But the more interesting question really is, why do many people live to be 20, 30, 40 years old, not have anything, and then suddenly develop symptoms of headache related to their Chiari malformation and or symptoms related to syringomyelia? And the way I envision this is that these tonsils, these cerebellar tonsils, are poised, if you will, at the door. They're just waiting. And a lot of things that we do in the course of our normal lives, like coughing or sneezing or yelling at somebody that we shouldn't be yelling at, or singing or blowing a trumpet or straining for a bowel movement, all of these things can produce an incremental creep, if you will, downward creep of those tonsils until we reach a point where, to use the old proverb, the straw that breaks the camel's back is reached. And so there's that one point at which the obstruction to cerebrospinal fluid becomes such as to cause symptoms. The obstruction, by the way, is never complete. It's never total. People who would have total obstruction of their spinal fluid circulation would present very differently, but it's not as easy for the fluid to get by. And I will, at the risk of paining some of you, will give you a analogy in just a moment. So to get back to that analogy of the slightly slow creep as we lead our normal lives, you can see that somebody who has a sudden bump to the head, whether it be a fall or a jarring experience, that can also be the increment that makes the difference between something that was present but asymptomatic and something that becomes symptomatic.
That's great. So a couple of questions have come in. I'm going to stick with some of the Chiari questions because they're sort of related. Do you recommend waiting to operate if a patient has a syrinx? If so, at what point do you decompress the Chiari to try to get rid of that syrinx? Or if not, do you decompress right away? And when you decompress, what's your take on opening the dura or resecting tonsils and all of that?
Okay. All right. Well, let me say something before addressing that question completely. The problem that I discussed before, the differentiation between true syringomyelia and a residual central canal, comes up over and over again. And unfortunately, radiologists, in order to cover all their bases, will use the term syringomyelia generously when they're really referring to residual central canal. So if I see a patient with a diagnosis of Chiari malformation and syringomyelia on paper, I am absolutely adamant about looking at the studies myself because I want to make sure that we're talking about the true syrinx cavity rather than the central canal. If they have symptoms related to their Chiari malformation, I would offer them surgery. If they have symptoms related to the central canal, I would look for other causes that might explain that. If they have a true syrinx cavity, I am in favor of doing surgery, decompressive surgery. And the reason I am is because, again, there are all degrees of spinal cord damage from a syrinx cavity, but once the spinal cord loses some of its cells or has damage to some of its tracts from a syrinx cavity, one cannot be certain that all function will be regained. Some of it may be, and we're just beginning to understand how some of the function can recover. But as a rule, I like not to run the risk of having somebody irreversible spinal cord symptoms of abnormalities if it can be corrected, and I favor doing surgery. Now, as to the type of surgery, there are many ways of doing this, and I am not here to tell you that I do it better. I'm here to tell you what I do and what I believe in, but also it needs to be emphasized that the responsive tissues in adults is different from the responsive tissues in small children. And the result of that is, as a result of that, you can do less in many small children with a Chiari malformation than you can in an adult. That said, I still am in favor of doing one operation rather than saying to somebody, we're going to do this, and if it doesn't work, we'll go back again. Excuse me just a second. So my formulation of the solution to this problem is for Chiari malformation is to remove that piston that Dr. Oldfield described from pushing down on the spinal fluid and driving it into the spinal cord. To do that, I like to have to recreate a normal spinal fluid space, which in technical terms is called a cisterna magna. And to do that, I need to expand the space a little bit. I showed you at the very beginning of this talk that the anatomy in Chiari patients is not always the same, and there are variations on the anatomy that results in a Chiari anomaly that may result in a slightly different surgical approach. But basically, I like to create a space so that the cerebellar tonsils are not crowded, and to allow normal pulsations to take place. And if you will forgive me, when I see patients, I often describe this rather crude analogy, but if you were to think of a wine bottle and you inadvertently pushed the cork into the neck of the wine bottle and turned it upside down, the wine would dribble out, but it wouldn't pour out. And the surgery that we do does two things. It makes the neck of the bottle bigger and the cork smaller. And so when you turn that bottle upside down, the wine pours out, i.e. the pressures are equalized. It's a crude analogy, but you get the picture.
It works. Related to that, do syringes typically collapse after decompression, or do they resolve on their own? A lot of people's syringomyelia tends to stick around. Is that something that's normal, or what about that?
Well, good question. My experience is that in small children who have a syrinx, the syrinx tends to collapse completely and may you may not be able to tell on an MR scan that there ever was a syrinx. In adults, because as I referred to before, the tissues in adults are firmer or different than they are in kids. It is unusual to get complete collapse of the syrinx. You can usually still tell a little line where the syrinx was. Sometimes you can even see a line that looks a little bit like a residual central canal, such as I mentioned before. And so my experience is that in adults, the syrinx gets much smaller, but it doesn't disappear completely. That said, probably the abnormal pressure within the cavity is eliminated, but the tissue is firmer, so it cannot collapse completely in that sense.
Okay. Sort of related to that, can a syrinx, even if it's resolved, can it cause neurological issues like even like seizure or something maybe along those lines?
Interesting question. I don't think the syrinx can cause a seizure because as we understand seizures today, we're talking about abnormal electrical activity in the cerebral hemispheres, not the cerebellum. And people can have, I mean, seizure abnormalities are not totally uncommon, and people can have some other reason for having a seizure. But there is something that I would like to touch on. We've actually published on this relatively recently. You can show slide number one. People who have had particularly a distended large syrinx for many years. Yeah, there we go. If you can enlarge that title page a little bit.
I'm not sure why it won't. Here, I'm just gonna do it this way.
Well, okay, I can talk about it. It doesn't matter. There we go. Just show the title, the upper part of it if you can. I don't know. There you go. In patients who have a syrinx, the pressure of the fluid cavity inside the spinal cord has the capacity of destroying some nerve cells. That's why many patients, historically, when syringomyelia was first described in the 19th century, had atrophy of the hands and weakness of the hands. That was sort of the classical presentation because there was cell loss. And what we've come to understand over the intervening years is that people with syringomyelia, particularly if they're adequately treated and treated in time, live a normal life expectancy. And all of us, as we get older, including your speaker here on the screen, we all lose nerve cells as we get older. The idea is that our nerve cells and their connections become a little bit more efficient as we grow older. And so we can get along with less, but we lose them. And this has been well studied for many, many years. And I don't know exactly when, but it was sometime in the 1900s, it was noted that patients who had polio and had weakness of a limb, an arm or leg, as a result of polio, which affected the nerve cells in the spinal cord, could make a complete recovery. But again, because they then went on to live a normal life expectancy, as they got older, their symptoms of leg weakness would recur without any evidence of infection. And it became apparent that people, as they got older and lost some nerve cells in the normal aging process, if they superimpose that nerve cell loss on the cell loss due to the polio, you can get recurrence of symptoms more likely to affect that leg that was originally affected. And this is known today and can be checked on as the post-polio syndrome. And it occurred to a number of us that the same thing can occur in patients who've had syringomyelia, who, thanks to better general care, including antibiotics for anything else, now can live a normal life, but may have recurrent symptoms, sometimes very mild, without any evidence of recurrent syringomyelia or expansion of their residual cavity by virtue of the same mechanism. And so we call this a post-syringomyelia syndrome. And we wrote a paper about this with one of the neurologists, Dr. Heiss at the NIH has also published on this, and it's generally recognized today.
That's really great. There was actually another question that kind of came up similar to that, asking if neurological symptoms are common later in life, and that sounds like what you're describing here, correct?
Yes, they
Okay.
can.
Okay,
I mean,
so
they should be investigated, obviously. I mean,
right.
not just listed, but that is the understanding.
Right. So there's a couple of questions about spine specifically, more, oh, not a little bit more generally if you really think about it. This one it uses big words, but I'm gonna make it a little bit less complicated. So they say, do cervical osteophytes, meaning bone spurs, contribute to CSF flow disorders? So could something like a bone spur, maybe in the cervical region of your neck, block fluid the same way maybe a Chiari would?
Excellent question. And if you look at the medical literature, there are a few cases, very uncommon, but there are a few cases in the literature report where a bone spur or even a cervical disc can be associated with syringomyelia. That said, I come back to what I talked about before. Is it possible that that patient, I mean, let me put it into broader perspective and say, first of all, that by far the greatest number of patients who have bone spurs in the cervical spine do not have syringomyelia. But the exceptional case where this occurs brings back the idea that I mentioned before, that maybe that's a person who had in the critical place a small focus of residual central canal, and that the obstruction that the bone spur produces is then enough to cause development of a syrinx cavity. But there have been, if you look at the medical literature, there have been instances described of cervical disc association with syringomyelia, but I don't think anybody has taken into account the possible role that residual central canal in these patients may be of significance.
That dovetails perfectly into the other question, which is if a patient should have a syrinx formation, and like you just insinuated, perhaps it's residual central canal, is anterior cervical discectomy and fusion the appropriate treatment?
Well, I'm not going to say specifically this patient, but I think an anterior cervical discectomy would remove the obstruction to the CSF flow. And if it is a true syrinx cavity, again, a true syrinx cavity, not a residual central canal that we're treating, then there's a good possibility that that scar tissue will, that narrowing of the space will be eliminated and the fluid will be able to pass by freely, and the syrinx will, the filling mechanism, as my late British colleague Bernard Williams used to say, the filling mechanism will have been disrupted, interrupted.
So there's a question about what's the possible role that tethered cord plays in the size of a syrinx, specifically in a person who may also have Chiari. If that person had a decompression and a large syrinx, would a detethering a few years later maybe also assist in decreasing that syrinx if it's still pretty large?
Well, this is an interesting question and a very complicated question. Just to put things into perspective for people who don't know, who are in the audience here, who don't know what a tethered cord is, as we grow from infancy to adult size, the spinal cord migrates upward in the spinal canal and assumes a more normal position around the first or second lumbar vertebra at the tip of the spinal cord. But there are a few people who have some strand or tissue strand or some other mechanism that prevents the spinal cord from moving upward in that fashion. And this may result in symptoms of leg weakness, leg pain, sometimes bowel or bladder problems. And the diagnosis is not that easily made because we have no way of measuring tension at the moment using an MR scan. We only have a visual image, and we have come to understand that there are some people who don't really have a very low position of the tip of the spinal cord who still can have tension on it. And related to this is the fact that some of these people have a small syrinx cavity in the lowest portion of the spinal cord. And after having given you a detailed explanation of how syrinxes develop, I will add that we have no idea how the syrinx develops in the lower portion of the spinal cord, because the mechanisms that I discussed above, where there's an obstruction of the subarachnoid space, don't apply in quite the same way. And so we don't have a clear understanding of why, but a so-called terminal syrinx is sometimes seen in association with a tethered cord. Now, no surgery is trivial, but sectioning the tether of the spinal cord, the so-called filum terminale, as it is called technically, is a relatively less formidable procedure than decompressing the cerebellum at the back of the head. The risks are smaller, the neurological complications are of a lower order, and the general view that I take is that if there's any question whether that patient's low-lying cerebellar tonsils is related to the fact that the spinal cord didn't migrate up properly, then I would probably favor, as a first step, to untether the spinal cord by sectioning the filum, and then see whether the patient improves.
Okay. I know we're going to go over by a little bit, so thanks for everyone sticking around, especially you, Dr. Batzdorf. But there are a couple of other really good questions that I think would be best answered by you. So I'm going to go to this one first. Is there a connection between Chiari, something called closed spina bifida? That's how it was described. And then maybe cancer and other kinds of different, I guess it would be autonomic symptoms. So this patient may or may not have an ostomy bag and sleep apnea, that kind of stuff. Are there connections between all those things?
Well, I have to separate the different components of this question. I'm not aware of any association between excuse me.
Stay hydrated.
Malformation and cancer. None whatsoever. Spina bifida occurs in different forms. There's spina bifida, which is called technically spina bifida aperta, meaning open, in which an infant is born with a bubble at the tip of the spine, which sometimes has nerve endings in it. But that is obviously recognized and usually requires immediate repair shortly after birth. What we're talking about is a less obvious form, so-called spina bifida occulta, occult, not obvious, in which there may be no external manifestation of an abnormality, or sometimes just a little dimple or a little tuft of hair. But if you look at the X-rays, the spine may not be completely fused in the middle as it normally is. So we have a space which is spina bifida, bifid, 2 points. And that is significant because that may be a point where nerve tissue, as well as the filum terminale, which is the non-nerve strand at the tip of the spinal cord, can become adherent because it's the normal tissue planes didn't develop. So spina bifida occulta may be associated with tethering of the spinal cord. Now, the other question, whether there could be autonomic symptoms related to it, well, again, that's a very complicated question. I think there are some patients with syringomyelia, and syringomyelia even due to Chiari malformation or primary spinal syringomyelia, who have autonomic symptoms, by which we mean difficulty sweating normally over the limb, and dryness of the skin may occur. There may be some microvascular changes. So those are all things that can be seen in conjunction with spina bifida occulta.
Interesting. This is a very interesting question. If there is one thing you could do research on to change neurosurgical care for connective tissue patients, what would it be?
Well, I don't consider myself an expert in connective tissue disorders, but obviously there's a whole spectrum of management, which in our institution is done by rheumatologists and by others. And I think my sense, having seen a number of patients with connective tissue disorders, is that we are probably still lumping disorders of a different etiologic origin together, and that therefore the treatment is not uniformly the same for everybody who has a connective tissue disorder. I'm reluctant to mention anything in particular because that's not my area of expertise, but I think there are in this country some specialty clinics where connective tissue disorders are segregated into different types and different origins, and more specific treatments can be offered on that basis.
Yes. This was interesting as well. After Chiari decompression, if the patient's still having some symptoms that before surgery may have been resolved after using a cervical collar and putting some traction on the spine there, is that something that you would recommend after surgery as well, or is that something that wouldn't be a good idea? And what about if there's some mild scoliosis issues there as well?
Okay, good question. basically, I'll answer this in two parts. I have seen any number of patients who have an abnormal curvature of their neck with or without a Chiari malformation. And I, in my own mind, have no doubt that spending, as a patient I saw today, 8 hours a day looking at a computer screen doesn't help matters. That's right. With neck pain. And neck pain, well, what many of these patients show, if you look at their imaging studies, is that the neck is straight. Normally, our neck curves slightly forward, but you can, I don't have any pictures of it here to show you, but you can imagine that if the muscles at the back of the neck are tightened, it would disrupt the normal curvature. And these muscles go into spasm and cause pain. And not only do they cause pain, but they're inserted right here at the back of the skull and cause pain in an area where patients with a Chiari malformation often have pain. So my first answer to the question is, if there's an abnormal curvature of the cervical spine, I like to teach patients how to do exercises that strengthen the muscles at the back and restore or try to restore normal curvature. And what these, I can actually show you, what you do is to put your hands at the back of the head and without moving your head, push your head into the closed palms. And I usually say count to 7. 1, 2, 3, 4, 5, 6, 7. Relax. 1, 2, 4, 5, 6, 7. Relax. And if you put your thumbs at the back of the head, as I'm doing right here, you can actually feel those muscles tighten up as you do that. And I tell patients to do 3 sets of 7 3 times a day. There's no magic to the 7. There's no magic to the 3 times a day, but there is a distinct improvement in neck pain. And once a patient has had a Chiari decompression, I don't think cervical traction should be done. I don't think that's a good idea. There should be other ways, such as the one that I showed just now, that might be, that are not going to put tissues that have been surgically disrupted on stretch.
Okay. Actually, that felt really good. I'm going to start doing that myself.
Yeah.
So one more question, that we have 2 more questions. One just came in. Do you recommend that Chiari patients get genetic testing? So would connective tissue disorders, as you kind of alluded to earlier, complicate their treatment because you don't necessarily know what the etiology is, where it begins? Would you recommend genetic testing?
As a rule, not. Not. I mean, even people who have a connective tissue disorder, many patients, unless they have evidence of instability on imaging studies, many patients can be treated completely adequately with a normal posterior fossa decompression procedure, unless there's some evidence of instability. And so routine genetic testing, I don't think is going to add much to it.
Okay. And then the last question is really interesting as well, and I hope you can speak to it. Do you know what the percentage is of people with spinal cord injury that develop syringomyelia in the first place? Do we know that number?
Well, that number varies a great deal, and it depends. It depends on what facilities are available. I've seen the older percentages where in the order of 5 and 10%, if you look at papers written or books written in the 1970s, they were 10, 20%. I strongly suspect that with modern imaging techniques, our diagnostic ability to identify post-traumatic syringomyelia is much, much better, and that the percentages are significantly higher.
Okay. Well,
It basically has to do with with two things. I should say two things. One is the availability of imaging, but the other is that, and here the older literature is very helpful. It is, if you look at books and papers written, I'm thinking of one in particular from the sort of 1970s, it was almost universal that patients who had a spinal cord injury and made a recovery, or a spine injury. It doesn't have to be even a spinal cord injury, because a spine injury can be enough to set up scar tissue. It would go for years, and it was not uncommon for people to have 20 years go by between their injury and the development of symptoms that led to the diagnosis of syringomyelia. This was not at all uncommon. It is, I'm sure, much less common today because we have a much lower index of suspicion or higher index of suspicion, the lower threshold for getting imaging studies.
It's interesting. Well, oh, okay, we got one last question. It just came through. This is going to be the last one. If a patient, this is a good one to end on actually. If a patient is still symptomatic after surgery and the syrinx isn't changing, is there anything else that a patient would be able to do? Maybe not neurosurgical. What would you recommend for someone like that?
The syrinx hasn't changed? Is that?
It hasn't, I assume it hasn't moved at all, gotten smaller. I have to assume it didn't get bigger as well, but they're still symptomatic.
And this is a patient with a Chiari or a patient with a primary spinal problem?
Ooh, that's a good question. Chiari, but I guess maybe if you could speak to both, that would be helpful.
Well, I can speak to both. I mean, my answer is the same in respect to both. My first line of approach to this problem of a persistent syrinx after decompression, whether it be decompression of the posterior fossa of a Chiari or decompression primary spinal, is to look to see whether the cerebrospinal fluid circulation pathways have been adequately opened. Scar tissue may form, there may be other reasons, and we can't go into all that detail here, but my first obligation is to make sure that the cerebrospinal fluid spaces have been adequately opened. Now, that said, Shane Tubbs wrote a paper, I think together with Dr. Oakes, I'm not quite sure, but I know he first authored it, of patients with persistent syringomyelia following a posterior fossa decompression. Everything and anything can happen. I had a patient who developed symptomatic Chiari malformation when she was probably in her 60s, and she had very good relief of symptoms, and in her 70s developed a syrinx cavity. She was completely decompressed. I don't know the answer. There is a small percentage of patients in whom you cannot find a cause for obstruction, which is not to say there isn't one, but yeah, there you go.
That's fine.
Thank you. So the first search should always be to try to see whether you've done an adequate job. And I recently had one patient in whom I thought I did an adequate job, and I went back in because I had no explanation and found a web of scar tissue that was too small to really be seen adequately on imaging studies. There's justification in primary spinal cases to do a myelogram, a myelo-CT, to look for a subtle obstruction that may not be seen on an MR scan. And I have a low threshold to recommend that in patients where I have no other explanation.
Would you recommend that maybe over a cine MRI? I know there's a lot of talk about those
Yes.
as well. Yes.
Yeah, I would definitely recommend a myelo CT over a cine MR scan in a patient like that. I think it gives, among other things, I mean, I'm a surgeon, so I like the idea of having an imaging study that shows me the problem is at this particular point, at this level. That's where you want to put your incision.
Yeah,
That
that
helps.
makes total sense. Yeah. Okay, well, I want to thank Dr. Batzdorf for answering all those questions. This was really, really, really helpful. I know we don't have a ton of pure spine stuff on our website like I wish we did, because it can be very debilitating. So it's really important that we talk about this stuff. But I just wanted to thank everyone for coming and for
Thank you for
being with us.
participating. Yes, thank you for your questions. Again, my thanks to Caitlin, to Mary, to Dorothy for arranging all this and making it happen. I think it's very, very useful to do this from time to time. Thank you and stay well.
Thank you.
Bye-bye.